Hello everyone, and thank you, Dr. Riem and Dr. Semah for your nice presentation. I present myself. I'm Dr. Yunus Arous from the Military Hospital of Tunis. I'm a professor in radiology, and we're gonna talk together about cardiac CT interpretation and the CADRATS classification. I'm sharing my screen now. So I think it's okay. So we all know that coronary CT has undergone a significant advancement and clinical validation in the last decade. Experts have issued guidelines and appropriate criteria, as it was done for prostate, breast, and thyroid. A standardized reporting system was published in 2016 and updated in 2022. And the main objective was to classify coronary artery diseases. Between the two classifications, there were two major modifications: the introduction of plaque burden grading and the ischemia. The other goals of this classification are to facilitate communication between radiologists and cardiologists and to suggest an adequate management. This table is very important, is to compare the two classifications. We can see that in the grading of stenosis, there were no change. For the plaque burden grading, it's on the 2.0 classification. And for the modifiers, there is a change in the vulnerable plaque is replaced by high-risk plaque. There was the introduction of ischemia. And now we will see how to interpret coronary CT. In our institution, we think that the first step should be always to assess the non-coronary item, such as lung, mediastinum, pericardium, valves, and cardiac cavities. Why? Because frequently we can find incidentaloma, so it's very important to start with non-coronary item to not forget to see them in the CT. The second step is to always to focus on congenital anomalies, of course, congenital coronary anomalies, such as bridge and anomaly of origin or of course. And the last step, which is the most important one, is to focus on coronary lumen and stenosis. And for the CADRATS classification, there is a CADRATS 0 for patient with no visible stenosis, the CADRATS 1 for minimal stenosis, the CADRATS 2 for mild stenosis, the CADRATS 3 for moderate stenosis, the CADRATS 4A and 4B for severe stenosis, and the CADRATS 5 for occlusion. And for stable chest pain, stable angina, for the CADRATS 0, 1, and 2, there is no specific management. For the CADRATS 3, the cardiologist should consider functional assessment. For the CADRATS 4, the cardiologist should consider coronarography or functional assessment. And for the CADRATS 5, the cardiologist should consider coronarography, functional, and or viability assessment. In case of acute chest pain, the classification is the same, but the cardiac investigation will, of course, change. For the plaque burden, there is 4 grading scale. For P1, it's a mild amount of atherosclerosis. P2 is moderate amount. P3 is severe amount. And P4 is extensive amount. Of course, we can easily understand if the coronary artery is normal with no atherosclerosis, So the patient is classified cadence 0. There is no need for to add a P in the classification because there is no plaque. And for assessing plaque burden, there is 3 methods: the calcium score, the segmental involvement score, and a visual score. In routine, we use the calcium score and the visual score in our institution because the segmental involvement score is maybe more difficult to use in clinical routine. So for the segment involvement score, it's a score for every artery segment. The calcium score, we know it's very easy to do now. It's automatic. And all the software are very easy to use. For the visual quantification, in the military hospital of Tunis, we use this method because we think that it's very easy, but of course it's very subjective. For the modifier, we can add N to the classification of the CT is non-diagnostic. We can add high-risk plaque. We can add S for stent, G for graft, I for ischemia, and E for exception. So if the CT is non-diagnostic, we can add N to classification. We see here the second segment of the right coronary artery, which is very, very difficult to assess. For the high-risk plaque, we know that there is a high risk of acute coronary syndrome, even if there is no significant stenosis, even if the patient is classified cadence 2, we can add a high-risk plaque to our classification. So what are the signs of the high-risk plaque? It's the positive remodeling, the low attenuation plaque, the presence of hyperdensity, peripheral hyperdensity, which is the napkin ring sign, or the presence of small spotty calcifications. We can add also S for stent, and a stent is classified like we classify a normal artery. We can also add G for graft, and as we see, I for ischemia. And for ischemia, we can assess it neither by myocardial perfusion or FFRCT. For the exception, there is the coronary dissection, the anomaly of origin, the aneurysm, vasculitis, coronary artery fistula, and other exceptions. Here, the case of a patient seen 1 month ago in the military hospital of Tunis is the left descending anterior artery. And we can see here in the first segment, on the very proximal segment of the left descending artery, a plaque responsible of a severe stenosis. Here we see the very narrow lumen with a hypodense plaque and a positive remodeling. We can also see here the stent of the distal left descending artery, which is normal. There is also a hypodense plaque in the third segment of the right coronary artery, which is responsible of a moderate stenosis. So this patient was classified 4A, P3, S for the stent, and high-risk plaque. The second patient, there is no stenosis. We can see here a small calcification of the proximal left descending anterior artery. no stenosis in the circumflex artery, and no stenosis in the right coronary artery. So this patient was classified Cadrats 1, P2. We will finish with the typical coronary CT report. So the first item should be the quality of the exam, then the congenital anomalies, then the presence or not of stenosis. And if there is a stenosis, it's very important to describe the exact site, the length, if there is a bifurcation near the stenosis, and the sign of a high-risk plaque. Then we describe the amount of atherosclerosis and the presence or not of modifiers. And the last thing in the report is, of course, the extra coronary anomalies. And thank you very much for your attention.